Are we ventilating wrong in cardiac arrest? What if our conservative ventilation strategy, 10 ventilations per minute, is actually lowering survival instead of contributing to survival? The rationale for ventilating conservatively is overventilation could theoretically create competing intrathoracic pressure within the chest. We don't want the pressure in the lungs impeding pressures within the heart. But that's not based on a lot of human data. That's really considered to be expert opinion based on more animal data than anything else. What if we could increase survival by increasing ventilations? This is a new paper that examines how often we ventilate in cardiac arrest, and there's two things that we need to understand about this paper before I get into it. Number one, this is a preprint, meaning it hasn't been published in a journal yet, and it hasn't been peer-reviewed. The reason why they circulate these preprints is to get some feedback on their processes behind the study. The conclusion of the studies don't usually change. It's just some inside baseball stuff that changes. Number two, the paper looks at in-hospital cardiac arrest, and data from in-hospital cardiac arrest doesn't necessarily inform practices from out-of-hospital cardiac arrest. Needless to say, this is for discussion purposes, and it's not meant to inform your practice. This paper looked at ventilation practices in 222 patients who suffered from in-hospital cardiac arrest. And they found that a majority of these patients actually received ventilations at a higher than recommended ventilatory rate, and so they created two cohorts. Patients who received between 6 to 12 breaths per minute and patients who received higher than 12 breaths per minute. And after adjusting for all patient variables, they found that ROSC was significantly higher in the cohort that received a higher ventilatory rate, even up to 26 breaths per minute. Now, ROSC is not survival. Survival was low across both cohorts, but these patients tend to be sicker when they arrest in hospital. While end-tidal was higher in patients receiving higher than normal ventilatory rates, PCO2 was unchanged between both cohorts, leading them to suspect that the higher rates of ROSC were due to the impact that the higher respiratory rates were having on hemodynamics. This needs to be peer-reviewed, published, and replicated with an RCT. So again, this is for discussion purposes only, but I will post the link to this paper in my bio.